With these two questions, what I have done, I have managed the risk of non-communication. If suppose you are not able to hear the voice of mine, or you are not able to see the slide, so then there was possibility of some harm. There is no use of this program. But I have checked. What I have done, I have mitigated the possibility of some unexpected happening. Same thing we have to do in our laboratories. If something has happened which is not acceptable, then if you are managing, what you are doing, occurrence management. Something has happened which is not acceptable. But here, what we will discuss, how to check vigilantly our laboratory operations. And we are finding something. If we are not improving in that area, some harm may occur. Now, first we will see some our day-to-day activities. Sometimes we find these in our lab. Look at this. The 35-year female. 1 ml blood was collected in 2 ml EDTA tube. Apparently, the CBC findings are looking normal. But clinician thought hemoglobin is normal, RBC is normal, MCV is low. There may be some hemoglobinopathy. And it is microcytic hypochromic picture. So it is better we go for iron studies and HPLC for hemoglobinopathy. When these two investigations were performed, these were normal. And when CBC sample was collected again and it was analyzed, it was normal. What was the reason? 1 ml blood was collected in 2 ml tube. Excess EDTA caused shrinkage of red cells. So MCV is low because of that, and hematocrit is calculated parameter in our analyzers. So hematocrit is also low, and you are finding ratio of hemoglobin and hematocrit is not maintained. So now this thing has happened. After that, laboratory initiated the action. Look at this. 40-year male came for routine health checkup. In this, they found hemoglobin low, TLC low, platelets are low, pancytopenia. So next investigation in line is bone marrow examination. But one clinician very intelligently noticed a clot. And when this sample was collected again, CBC was normal. Similarly, we will discuss briefly some other examples. What we have to do, we have to be very careful in our laboratory. These possibility, we are reducing the possibility of these happenings in our laboratory. So with that, what we are doing, we are carrying out this risk management. See, in this case of pancreatitis, serum was highly lipemic. Hemoglobin was very high, TLC was very high. They thought that this is a case of some myeloproliferative disorder, maybe polycythemia vera. Then they thought this lipemia causes pseudoleukocytosis and pseudo increase in the hemoglobin. Similarly, in another example, patient was receiving IV fluids because of dehydration. Blood findings were low hemoglobin, low TLC, low platelet. Then in this case, laboratory people were little careful. They thought it is better first to check how the sample is collected. Then they realized sample was collected from the same arm where the patient was receiving IV fluid. When repeat sample was collected from other arm, everything normal. So we have to be very careful in our laboratory activity, particularly in pre-examination, because 80 to 85% errors occur in the pre-examination phase, and we don't have any automation for that. We can do barcoding, we can have pneumatic chute, but we have to be very careful in our pre-examination. See, Similar to pre-examination, careful interpretation is very important. Hemoglobin 6.6, MCV 88. And they ruled out nutrition deficiency because of this normal MCV. This is normocytic normochromic anemia, but it was dual deficiency, iron and B12 deficiency both. And when hematinics were given, patient improved. Only one blood culture sample sent to laboratory to rule out infective endocarditis. You can very well imagine how serious this condition is, infective endocarditis. So ideally, we should follow proper protocol. Paired sample is collected and 3 times in a day samples are collected, because if we are able to identify infective endocarditis, that is good for the patient. Otherwise, there may be danger to life. Information on specimen is not matching with test request form, then something may happen, which is catastrophic. When we will discuss scoring also in this risk management. So you have to see what type of score shall be given to a particular situation. Now see how important this is, biological reference interval. Laboratory changed the biological reference interval from 20 to 96 to 100 to 250. And they didn't inform the clinician. If we have changed the kit and the biological reference interval is different, clinician interpreted, how? A case of gallstone, alkaline phosphatase was 72. And after 2-3 days, when they repeated, it was changed. And now it is 226. For laboratory, both reports were normal, but clinician, how they interpreted, alkaline phosphatase has increased from 72 to 220. Probably some gallstone has slipped from gallbladder to common bile duct. They planned ERCP. And yes, when ERCP normal, they contacted laboratory. Shall we suspect some bone disease in this? Because alkaline phosphatase is high. And now the laboratory is telling, oh, no, not at all. Don't worry. What we have changed the kits. Unnecessary trouble for the patient, discomfort for the patient, so much stress in the mind, and unnecessary patient underwent this intervention. Typing mistake. Again, this should be avoided. Report is handed over to some other person. Wrong report. Or report is handed over to person who is not connected with that patient. So some misinterpretation may occur. See, we have to very careful in our laboratory. 70% clinical decisions are based on our report. Clinicians, they expect error-free report, which is meaningful for them. They can make correct diagnosis. They can start correct treatment. And as a laboratory person, we are contributing in the better patient care. This is the expectation. For this, we tell our clinician, we tell our users, we are assuring you about the quality. You will get the correct report, and that correct report within committed time frame. They may ask, okay, you are saying quality requirements will be fulfilled, but how? We are following good quality control, not only in our examination, ki running IQC requires. We are participating in, we are ensuring quality in our pre-examination phase, as well as in our post-examination phase, and in examination also in addition to IQC and EQUAS. So for this, what we have done, we have developed a good quality management system in our laboratory, which is based on international standard ISO 15189. See, every laboratory has the same sequence of events, whether it is small laboratory, large laboratory. But where is the difference? Every laboratory receiving request, they are collecting sample, transporting sample, receiving in the lab. Every laboratory is carrying out the same process. But what is the difference between a good laboratory and not so good laboratory? A good laboratory has well documented procedures at each step. When laboratory is following these procedures, chances of errors are reduced. Chances of some harm to the patient are reduced. So this is what expected from the laboratory. And if you are able to convert your laboratory activities in the processes, sequence of activity, and you are developing detailed instruction or procedure for each step, then it is easy for the laboratory people to follow and chances of errors are reduced. See, these are our activities in the laboratory. Our pre-examination activity, examination activity, post-examination activity. To carry out these activities in a required manner and to cause minimum dissatisfaction for the patient and to work in a manner chances of errors are reduced, what we have to do? If somebody is not happy, there is some complaint, these are resolved. If some work is not in conformance with our documented system, we are checking that, taking appropriate action. We are looking in our laboratory for continual improvement. We are checking various activities regularly. For this, what we are doing and for the validity of examination results also, we are developing a good structure in our laboratory. How people will report to higher level. What is our organogram, organization structure? We are discussing with the management. What is our expectation? What is our requirement from the management? Management is also discussing what is their expectation from the laboratory. We are developing good quality management system, proper document control and control of all records. For this, what is required? Personnel working in the laboratory shall have required education, shall have required training and experience, so that they are able to carry out their activities in a required manner. Facilities, environmental conditions are well maintained, adequate space is there, equipments are well calibrated, well maintained, reagents are of appropriate quality, and we are ensuring quality requirements before using these reagents for patient testing. And whatever consumables we are buying, we are checking them for the quality. And whatever information we are generating, why we are keeping? So that if it is required in the future. So for this, we have to maintain data in such a manner they remain retrievable and confidentiality of the data is maintained. I am just discussing with you one example of a process. As we are discussing, laboratory shall develop process. See, it is process for your pre-examination. You are developing list of tests and labels, patient is identified, samples are collected, samples are labeled, then transported to the laboratory and there the samples are received. For each of these steps, you need detailed information. Maybe some procedure. How you will identify patient in the OPD, how you will identify patient in the emergency. Some patient may be comatose. How you will identify that patient. You are collecting different type of samples. What is the procedure to collect? Arterial sample, capillary sample, venipuncture. So that way we need sequence of activity This may vary from laboratory to laboratory. So whatever is the system that need to be followed, first sequence of activity and procedure at each step. What you need, because this quality management system, it is not like that. Previously, we were not maintaining quality. We were maintaining quality, but we were maintaining quality according to our standing, our understanding, our knowledge. Different organizations were maintaining quality in a different way. But globally, people thought sometimes a patient is coming to a hospital from suppose neighboring city, and the hospital is saying now you have to undergo this testing again. Again, what is happening? Discomfort for the patient, some financial burden also, treatment also getting delayed. To avoid all these things, if we can develop a system so that patient tested once need not be tested again and again, it is good for everyone. So with that intention, this ISO 15189 is developed. So all of us are learning this by reading this again and again, and this is what expected from each one of us. So only practice can make us perfect, right?
Based on that, because when we can say that this small child, this small baby is self, himself is trying to manage the risk that I may fall in from the bed, but I have to do this work. I want to do this, accomplish this work. What this baby is doing, baby is identifying that there is some risk I may fall, and then estimating. So, and then taking some action also to mitigate. The same we have to apply in our laboratories, that how we should act up. So if we define that, we have to first of all define a risk statement. Whenever we want to do some risk assessment activity, there should be a risk statement that what actually we want to achieve. So if we have to define an overall goal that to reduce adverse consequences to an acceptable level, because risk cannot be achieved completely mitigated always. So we have to assign some acceptable level, that up to this level we will achieve, and that will be for us. And this has to be done for every activity in the laboratory throughout all the testing processes, pre-testing and post-testing processes. So first of all, we have to define the target, objective or goal. Then we can further move ahead. So when we talk about this, we will definitely encounter a few terms which we should be very clear about. First of all, tell me, am I clearly audible? Is my voice clear?
Dr. Rinu, you are clearly audible,
Okay.
but sometimes
Okay.
there is some noise in the background.
Noise in the background. So is it okay now?
It is okay now.
Okay. So there will be few frequently used terms when we study this risk assessment activity, that what is actually risk. The risk is harm that can occur due to a vulnerability or deviation in the process, which can be avoided or minimized by a few preemptive actions, that proactively we can do something which can minimize that. And what is the failure mode? This is very frequently we hear that failure mode and effect analysis. So what is that? What is failure mode? Failure mode is the manner in which a process could potentially fail. It has not failed yet, but the manner, the way, what can be the possibility that this failure can occur. That is called failure mode. And the analysis of that is called the failure mode and effect analysis. And this is fishbone diagram, where we frequently encounter this term. This is basically done to analyze the causes. When we identify what all causes we have identified, we can enlist it, and it becomes a easy approach when things are in a listing manner. So this, as Dr. Jain has told in his presentation, that this is a laboratory which is a normal laboratory, but when we apply certain processes or procedures at each step, a defined approach is that we control risk at many cases. So this is definition as per 14971 ISO document, which is basically meant for risk management in industries. So this is systematic application of management policies, procedures, and practices. The task of analyzing, evaluating, controlling, and monitoring risk. So this is overall the risk management. So basically, it is a process that involves anticipating what could go wrong, assessing that the probability, what is the probability of any occurrence, what is the consequence, and what harm they can cause, and finally, what can be done to reduce this potential harm to an acceptable level. Just always remember that we can just reduce it to acceptable level. That should be acceptable to the organization. So basically, risk is a measure of severity of impact of potential error. Mind it is a potential error. It has not occurred yet, which is multiplied by the probability of its occurrence, how frequently it can occur. So this will give us a measure. So like in this slide, there are so many risk activities going on. On one bicycle, three people are going. One female is talking on the phone, riding bicycle without helmet. One person is crossing the road. What they are doing is they are just um, giving opportunity for multiple risk. So the concept of risk is actually not new. It is just new to us means in medical laboratories. Otherwise in health, otherwise overall industries, they have been talking about this for years together. So in healthcare, patient safety programs, medical laboratories, from ISO 15189 in 2003, we started talking about risk in our medical documents. So why it is important for medical laboratories? We all know that tests are performed only once. So if something goes wrong, your reports will be wrong. And that test result will be used for clinical interpretation for patient management. So catastrophic the things can be. That is why this is important that we do some management activity that risk of wrong report is not there. We analyze many samples from which we derive information. That information is useful clinically. The information impacts upon decision making of health patients. Poor information, if the information is wrong, the outcome will be poor. And apart from all these things, it has now become standard requirement with that we have to follow a certain regulatory requirements also, which guide us that we have managed risk in laboratories. So because we all know that laboratory errors, they cost us, if it occurs, it will consume our time, it will consume our personal efforts, and the patient outcome will be poor. That is why it's better that we have a proactive. So what standard talks about risk in medical laboratories? 15189/2022, which is basically requirement for quality and competence, and in 8.5.1, 8.5.2, and 5.6. These clauses talk about risk mainly. Medical laboratories, when we say 15189/2022, along with that, we know that there is one dedicated standard. Please remember, 15189 के साथ there is ISO 22367/2020, which talks about medical laboratories application of risk management to medical laboratories. It mainly provides us risk management framework. So one standard is providing us quality management framework, the other standard is providing us risk management framework, and we can use both of them, apply in medical laboratories to reduce risk. So as I have told you, and you all know that 5.6 tells us, ISO 15189/2020, clause number 5.6, it talks about risk management, that all laboratories, management, they have to establish, implement, and maintain processes for identifying risk of harm to patients and opportunities for improved patient care associated with its examination activities, develop some actions to address both risk and opportunities for improvement. So we have to develop a process for it. So one document which is required from standards, we should have a process. Then there comes opportunities for it. So 8.5.1 and 8.5.2. These two standards talk about managing risk and so it will be worthy, but it will be wise to say that it takes less time to do things right than to explain why you did it wrong. So when we have a proactive approach, the errors will be minimized. So now coming to the risk management process, the actual steps. So please try to remember this. It's a very simple approach. Step 1 to step 6. First of all, we have to plan. There should be risk management plan. Step 2 is risk analysis. We'll understand as we go forward how to perform risk analysis. Then step 3, risk evaluation. Then control. Step 5 is management review. And 6 is monitoring of risk. So as per ISO 31009, the risk management flowchart process can be like this. Establishing the context, first of all, as we have read in the beginning only, that we have to define a risk statement. So establish a context, what actually we want to achieve. Develop some risk criteria. Based on that, identify risk. What can happen, when can happen, where, how, and why. So many W's. After that, once you have identified, analyze. Depending upon considering the likelihood and consequence of that particular risk activity and estimate a level. So this is called risk estimation. So what we have done, identification and estimation. These two put together, this is called risk analysis. When we give it a likelihood number, consequence number and estimate the level, it is called risk analysis. Once we have identified and analyzed, now we have to check how valuable it is to go further. So we have to evaluate against the existing criteria, decide on response and establish the priorities. Once we have given exact number to particular activity, then only we can prioritize which action to be taken first, which to be taken later. So this whole exercise, identification, analysis and evaluation, comprises of risk assessment. You can see here a big box. This is risk assessment. Once you have done this risk assessment, you can treat that risk. Treatment includes either mitigating or controlling or minimizing. So this whole process is to be monitored and reviewed, and it should be put to the management review. Again, ISO 2367 talks about a process which can be simplified like this. You have to identify people at risk or position or the risk activity. Identify existing control measures. Do you have something? Suppose there is, if for example, if I say there is chance of hemolysis while collecting sample, what process we have exactly? We have a vacutainer system, so that there is no need to push the blood in the vacutainer. So this will minimize the effect of this. So this control measure I already have. What further can be done? If there is something to be done added to that, we have to evaluate on the basis of likelihood and severity of consequence. Calculate and make a ranking. Risk ranking to be done based on very low risk, medium, high or very high risk. If there is very low risk and no action is needed, it is acceptable. If it is low and possible, maybe no action. Medium risk, maybe of medium priority action is needed. Depending upon that, we have to implement control measures. Once these control measures are applied, we again have to re-evaluate whether after applying these control measures, is there further need for some action? How much residual risk is there? So if after that there is no or lower risk acceptable, if there is some higher risk again, then we have to implement new control measures and we have to repeat the whole process. We will understand, this is basic, we will understand further what all words mean. So first step 1 is risk management plan. What all is to be done in planning? So first of all, define scope. what area we want. Yes. Assign responsibilities and authorities. Who will do what authority will do, who can take decisions, who can arrange for resources, if there is controls required. Specify risk management reviews. Before applying some control activity, specify what all review criteria be used. Define criteria for risk acceptability also. So in the planning only, we are doing specify verification, risk monitoring, and optimization. So this is to be done in risk management plan. Then comes the analysis part. So as we have learned that analysis is identify hazard and estimate risk. We can say it higher. HIR, hazard identification and risk estimation. So according to the definitions, the hazard is cannot result in harm until exposure to hazard occurs. If it is sitting somewhere, hazard, it will not cause you harm. But some exposure has to happen. If some acid bottle is kept on the corner, it will not cause harm. But when it is spilled or it is causing some physical injury to person, it is harm. So this is example that a hazard is not hazard until it is something is exposure is being done. So always remember that hazard is proactive approach to identify. So how to identify? How will you identify risk in your laboratory? Can someone suggest how to identify in the chat box? Yeah, responses please, because I want directive session from sites. Yeah. How can you identify risk? Yeah, someone? So we can identify risk by anticipating what could go wrong. What are the circumstances or scenarios that can be realistically expected to occur that may lead to injury or ill health or threat to patients or employee safety? We can review the existing processes. Each step of process will help us identify the risk in that process. What are the unwanted circumstances that may arise? So these are the activities we have to just have brainstorming sessions among our team members, among with the management, review of the existing processes, discussion with the team will help us in identifying skills. We can use feedback from users. We can note daily observations. We can have input from our laboratory team because frontliners are the main resource who can provide us very well information. They, in and out, they are facing the patients. They are the workforce. They can give us the best feedback that this can be done, this can be risky in our lab. You can identify risk from your internal audit reports. Whenever a new process is introduced, always check what all risk can be there in a new process. So according to areas also you can identify, you can focus on infrastructure, staff, equipment, IT related risk, reagents or consumable related risk. So likewise, if you have a structured approach to identify, you will be able to identify and enlist. Otherwise, without structured approach, you will be puzzled. You will just be ending up into thinking this is wrong, that is wrong, this is correct, that is correct. So we have to enlist, we have to note down. So actually what is estimation is giving a value to something. Is estimation to assign values to the probability of occurrence and the severity of harm. How to do that? How can we assign values? So these are few examples which standards, the multiple standards talk about estimating probability of harm. Overall probability can be assessed, can be given like semi-quantitative approach can be like each day, each week, each month or each year or once in a year. For each level, you can give 1 to 5 levels, and you can term it as frequent, reasonably likely, occasional, remote, or unlikely. So whenever you think upon some risk activity, think like that. If it is happening each day, it is frequent, give level 5. If it is happening each week, it is reasonably likely, so we can give 4. Each month, occasional, level 3. Each year, remote, level 2. Less than in a year, unlikely, so it is level 1. And similarly, we have a qualitative also, scale also. Frequent is which is likely to occur regularly with the examination procedure and expected to be experienced continuously in the laboratory. It is level 5. Likely to occur multiple times. It is reasonably likely, level 4. Likely to occur sometimes, comes occasional, level 3. Unlikely to occur but possible with examination procedures. So it will be put in level 2, the remote possibility. And it is extremely likely to occur with examination procedures. This will be unlikely, level 1. So this was all our probability of occurrence. Now I come to the severity scale. So severity again depending upon the outcome. So if it is life-threatening or death, it will be considered as critical category, score 5. If it some risk is giving, some activity is giving permanent or irreversible bodily damage or impairment, it will be considered as serious injury, score 4. If it is a non-permanent damage or impairment which is reversible with medical intervention, significant category, score 3. Temporary body damage and reversible without any medical intervention, it is considered as marginal risk, and score of 2 can be given. And if it is only a temporary discomfort, no injury has been caused, the effect will be negligible, and score 1. So like this, severity and occurrence scale, we can give a score to that particular risk. So when we multiply probability and severity, it gives us an inherent risk level, A into B. So we'll learn it in further slides. So then we have to evaluate. So evaluation is comparing the estimated risk against given criteria and determine the acceptability of risk. So we can compare that what was before and what was after that. This is risk matrix in 5 into 5 grade, where we on a 1 to 5 grade scale, we put it together on the x-axis and y-axis, the probability and severity. So multiplying A and B gives us a risk score. We can put it in risk matrix, and where it is marked as red, it is high risk. We have to take action. Yellow may be acceptable, may be taken in second event. First of all, prioritize based on this risk score number. The risk areas which have higher number can be taken first. So like if we take this approach, it becomes easy for us that the identified causes can be listed, can be given number, and we can decide which identified risk can be taken first. One more approach you will often encounter, that what is FMEA. So like risk matrix approach 5 into 5 grid, we have failure mode and effect analysis, which includes RPM, risk priority number. It apart from severity and occurrence, it includes detectability also. So in RPM, the risk severity level, as we have done in the previous approach, probability of occurrence multiplied by detectability. Like what are the measures, existing measures that we can detect that risk activity. So FMEA basically it is a process effect. Wherever a process is there, we can check the various steps of that process by this analysis. So in this process FMEA, what happens is that possible failure modes are identified by brainstorming with the team. Potential effect of each failure mode is identified. If this goes wrong, what will be the effect? Then severity, likelihood and detectability is given number and we can calculate RPM. So like this, like we have done in risk matrix tool, similarly in likelihood in 1 in 10 scale, FMEA scale, we can give number from 1 to 10 like this. You can have a picture of this so that it will help you in the activity which we are going to do today. So this is likelihood scale from 1 very low, very high, 10. And similarly, the criteria are there. Failure, eliminated, prevented, control activity already in place. Failure never occurred. Once in 5 to 10 years, annually, biannually. So what is the likelihood of that risk? Similarly, the severity 1 to 10 scale is there. If number 1, no effect. Customer not annoyed, number 2. Customer slightly annoyed, number 3. And likewise, up to highest level, which is hazardous mortality, given as number 10. Please click a picture of this so that it will help you in the exercises which we'll do later. So then comes the detectability. What existing control measures are there which will help us in detecting that do we have something that this error can be identified in our existing system. This is detected. Do we have something, some control measure in our system that I can identify that this particular risk will not result in harm? Do we have something in our system? Like, for example, if there is a risk of fire in a laboratory. So what all system we have in place? Do we have fire extinguishers? Do we have trained manpower? If it happens, will we be able to control? Is there risk of fire in our laboratory? So this is detected. Then based on that, we have to do risk evaluation. The probability of occurrence, we call it how frequent it is there. O, the severity, how severe the risk will be. S, and the detectability is given as D. So if we multiply OSD, it becomes RPM, risk priority number. So as a general rule, the cutoff is placed as more than 100. Whenever the scale number is more than 100, we should consider it as some mitigation, risk control measure is to be taken. When we say fishbone diagram, basically it tells us we can have a structure so that all the identified causes can be placed in various verticals. And when we have some structured way of doing identifying something, we will not miss even a single cause like man, machine, method, measurement, material or mother nature. So under these headings, if we are putting something, we will not miss any of the cause. For example, I have this for you. In a laboratory, in a 24/7 laboratory, if there is, we can consider in a 24/7 laboratory, if there is no QC run protocol in the evening hours, they are just running QC in morning. So what will happen? There is quite likely that they will not able to detect the wrong result if released in evening. So why do we have QC, quality control, internal quality control? QC means internal quality. Why do we have this? So that we know that our results are correct before patient samples are processed. So if they do not have some system of IQC in evening hours, what will happen? There are quite likely chances that patient results which are released in the evening may go wrong. There are chances. So for that, how we can proceed is we can just enlist few causes that why QC run no QC in the evening. Maybe there is no existing protocol in the system, no procedure of placing control, of running control, or there can be that they do have a process but they have not trained, or there is no instruction available at the bench where technicians are performing this. So they do not know when to perform, how to perform. And if there is that is available but no QC rules have been defined, so they will accept everything. And if in case there is some wrong outlier in the QC, what will happen? The sample result will be. Similarly, we can have person related things also. Person, maybe inadequate training of the staff on IQC procedure. Maybe there is some newly recruited staff who does not know that what and when to run the controls. Maybe sometimes workload related issues also. If there is no QC in the evening and workload is very, very high in the night hours, what will happen? High samples, maybe there will be more number of samples in the evening that might go wrong. So maybe the laboratory had thought in the beginning that because the numbers or number of samples in the evening are less, so why should we process the control? So leave it. But they have not thought about that if the workload suddenly increases, so there will be more samples that may go wrong. Like equipment, maybe some malfunction in the evening hours, and if there is no QC run protocol in the evening, after malfunction or breakdown, there'll be no checking whether something has happened with the equipment. After that, repair and the samples processed after that wrong. Maybe there is material related issues like some new kit, not calibrated reagent is there in the system. If there is a QC run protocol, that will detect all the challenges. Like environment related, maybe sudden electricity failure in the lab. And after that, when machine is switched on, there is no protocol. What will happen? We will not be able to detect that some outlier is there because there is no system of running QC. So this is how we have so many causes, so many areas where if laboratory is not using controls in the evening, there are quite likely chances that patients result. Basis that we can have this estimation done. So, for example, I have done for like we have discussed that there is no protocol. If there is no protocol in the system, the root cause is why there is no protocol, because the management has not developed any protocol itself, or if they have protocol in place but they have no acceptance rule in the system, or if they have everything but they have not given it to the users who WTI. So because there is nothing, we can give existing control measure is no. So when there is no existing control measure, the detectability becomes high. Now go to that slide, which gives us, you must have clicked pictures. This is detect. So no mechanism to identify the defect is 10. So there will be almost certain. So that is why we have given it 10. So when the detectability is not there and some sample is being run without any QC, there will be quite likely chances that wrong result will be released. So occurrence will be high. And if wrong result is produced, the severity of impact will be high. So 10 into 10 into 9 becomes 900. The risk priority number is high. More than 100, we have to definitely take some action. For that, what laboratory has done, they have developed a protocol, they have developed a WTI of running QC in the evening or night hours, which is readily available to all the staff. Acceptance criteria have been defined. They have another protocol also along with that, that they will run retained samples along with QC, and training to the lab has been given. Evaluation has been done. So these all measures have been taken. With this, the detectability becomes one. They can easily detect. If they have a protocol, they can detect outlier easily. Trained staff can detect outlier easily. So they have taken all the measures to detect that. So becomes one. So detectability, the easier is the detectability, the lesser is the number. Just remember this. You have to clearly remember that easier detectability, lower number. The occurrence will be less when the detectability is there. Obviously, we can detect, and the occurrences will be, the number of opportunities will be lesser. We will be able to identify the outlier, we will take some action, and we will not process patient samples. So our patient results will not be wrong. But sometimes if it may happen, if it occurs, that the severity remains always high. But the RPN becomes 20. So where it was 900 when there was no control measure, now it has become 20. So the action is, the plan is okay. So they have to take some measures on that. They have to procure quality control for extra control. So they may have to seek some permissions that we will now use more control bottles. Maybe our cost goes high. So they have to discuss this thing in their management report. And they should monitor it further, that whatever action has been taken is effective. So this was the control. So based on the position and risk matrix tool, we have to decide the action plan to identify the quantity and type of resources what will be needed to carry out the actions, develop the action plan, obtain management approval, and do risk benefit analysis. Whether the risk was good or the benefit which we have is good, and put it for the management review. The review is the process, review the process that the risk management plan has been appropriately implemented or not. The risk from all the identified potential hazardous situations have been considered or not. The overall residual risk is acceptable or not. The appropriate methods are in place to obtain the information necessary to monitor risk. Whether there is appropriate method that we can monitor it further or not. Then go ahead for risk monitoring. Monitor that risk further. Are we still having some positions where samples might, where our results might be wrong in evening hours? Is it? So check if these risk reduction efforts have been effective. Maybe some new technician further joins and you have not trained that person in the evening. The person is posted on duty. Again, the situation will come to the same level. Always monitor. Measure the residual risk. What is residual risk? The risk remaining after the control actions have been taken. And we are accepting that. That is residual risk. Always establish a surveillance system. Once you have applied these control measures, how you are going to monitor that further there is no risk or the acceptable risk has been achieved. Monitor in terms of indicators, because indicators tells us how we are going ahead, whether we are improving or we are not improving. So define indicators. Detect changes, whether risk profile has been reduced or not, whether from 100 or 200 we have come down or not. So monitor that. When it is to be done, it is a big question. When this risk activity management activity is to be performed. So initially it should be done when we are starting a new laboratory or organization, and then every year it is to be done. Whenever there's some incident or accident happens, always do this activity. If you are having some new equipment, new test, or some new process is introduced, do this activity. Change in your work process, perform this activity. And once it is stable, frequency can be reduced. So what is residual risk? The risk remaining after risk control measures. Prior to implementing a proposed change, it is important to ensure that any individual risk, basically it is so many identified causes were there and each cause has its individual residual risk. So we have to find out that we have to ensure that any individual residual risk as well as the overall risk are defined and they remain acceptable. It has to be acceptable also. What all documents are required? So SOPs are required, process flow charts is required, which includes risk analysis, evaluation, implementation and verification of risk control measures, assessment of risk acceptability and residual risk. Another measure tool which we require is risk matrix tool or RPN calculator should be there. Tools like fishbone analysis if you are using, otherwise it is not mandatory. You can use risk identification in the form of table only, but just apply a strategic approach. Just remember that. Then we have to have some management review records with us, monitoring of risk control measures, indicators we should have, and other supporting documents like internal audit reports, your staff discussions, your brainstorming sessions, your identification tables. These should be. So with this, I can say that doing all these activities, maybe I have not achieved that, but I am certainly closer to what I was yesterday. So one step, little step can make all the difference. Always remember this. Now we will learn a few real-time scenarios for your just practice. Start with this risk statement activity that in a laboratory or in an organization, they want to evaluate and mitigate the risk of transmission of infection to staff and colleagues by COVID-19. It was when this COVID-19 infection, this illness was starting in the beginning only. Suppose we go 4 years back and we started facing that situation and it had begun, but there were things in the air that this virus is spreading fast and we may have admit patients in our organizations also. So this was those times. So in that laboratory or organization, they have tried identifying risk of infection transmission to staff, to employees, and to other patients from COVID-19 exposure. So what all risks are there and what is to be done to minimize that. So they have used this structured approach of enlisting the causes, dividing into protocol related, infrastructure related, person related, workload related, and inventory related. So protocol may, first of all, they have defined that there is no existing protocol for handling and discarding COVID-19 patient samples. So this, they identified that it is not there. When it is not there, the exposure to this will happen and our staff or employees might be exposed to infection. Then infrastructure related, this thought that there is no screening of patients which may lead to contact of undiagnosed COVID patients with laboratory staff for sampling or other lab-related verification. So this was one thing for which they wanted, they had to add some structural change. Person related, because lab staff is not trained to handle COVID-19 samples, positive samples, and if persons handling those samples are not handling the exposure will result in infection. So workload related causes, some risk was there that same staff caters to routine samples and not samples which may lead to exposure and risk of transmission. And inventory related, maybe they were not aware of how to protect and whether it will be available. So these all, there can be many more, but for just making this understanding clear, we have kept it simple. So when we apply this risk estimation RPN, calculation of RPN to each every cause, the thing will be like this. So what is the failure mode? What is the cause? What is the existing measure applicable? What is the likelihood, occurrence and severity? What is the RPN? What corrective action was taken? What was the detectability after applying this control measure? What will be the occurrence? What will be the severity? And then the after application RPN. So this like this, the mixing of COVID, the failure mode can be that there might be mixing of COVID and non-COVID samples. What was the cause they had identified? Because there was no written protocol. So when there is no written protocol, no training, no process in place, there will be definitely mixing of samples. So there was no existing control measure. That is why, because no SOP was available, the detection could not be there. So highest likelihood of non-detection. So the number is 10. So when there is no detection measure, the occurrence will be highest, number is 10. The severity will be high, and 9. So the score will be R. You can refer to those pictures which I had told you, that you can click pictures of those tables. You can refer to that. And if Melap organization, if is there, is it possible to share that sheet with them? So kindly share. So what corrective measure were taken? That protocols with regard to receiving, processing and discarding of COVID samples was defined in the laboratory. After that, because everything was defined, the detectability became frequent. So this could be given as number 2. The occurrence will be definitely less, comes to 2, and the severity definitely will remain high if happens. If exposure happens, the severity, the RPN comes to 6. So similarly, they have contact of another failure, contact of undiagnosed COVID patients with the laboratory staff. So why? Because there was no screening protocol in the laboratory or in the hospital premises, and every undiagnosed patient or every flu patient were entering from the same gate. So there was quite high chances that there was mixing of these patients. The existing control measure comes to none. The likelihood of detection was not able to detect. Number 10, occurrence high occurrence, quite frequent. Say 10, severity 9, 900. What they did, they created triage areas, flu corner, avoid contact of suspected patients with the staff or other patients. Detectability became like it became 5 because because there were still a few patients who were not diagnosed, who were not disclosing that they had this flu type of symptoms, and they were entering from the same. They were not filling the registration form. They were not revealing this. So because of that, the detectability still was not that easy to detect, but it came from 10 came 5. A few cases definitely were detected at the entry. So occurrence, definitely it came down from 10 to 7, but yeah, no, because mixing of patients were still there and the severity remained high. So the score, which was 315, even after this control measure was taken. But this is the residual risk which hospital had accepted. So this was the acceptance level. So this is what we have discussed in that organization has to define some acceptability, right? And define on acceptance on residual risk. So in this example, I just wanted to that because organization from the starting itself has defined as accepted that they moved ahead. So the third failure mode could be lab staff not aware of how to handle samples. The COVID positive PCR samples, they were not trained. So root cause was the staff was not trained. the training of the staff was a cause that exposure might happen. So again, the likelihood was 10, detection was not possible, the occurrence was 10, severity was 9, RPN of 900. So what they did training, robust training staff, the detective came high, it came to 2. The occurrence, if it happened, was 8, severity remained same. Again, the score reduced from 900 to 144, but they accepted. Staff, same staff catering to both the COVID and non-COVID patients. What was the cause? Because the job responsibilities were not allocated in the organization. Who will have whom? So existing control measure none. The likelihood of detection was low. Occurrence was high. Severity was 9. And when they dedicated staff was posted in the flu corner, they were not allowed to go to other areas. The detective came very quick, good detective. Likewise, it came to 63. Improper use of CPE was one more failure mode that happened. Why? Because unawareness of the staff that how to use that. So likewise, from 900 it has become 80. So this is how this laboratory or organization from the starting only planned that what all risk opportunities will be and how will we tackle those opportunities. So this is similarly you can apply the process in your laboratory from the simple process pre-analytical, just pick up pre-analytical, just pick up mixing, proper improper mixing of sample and make a report. If you are in the process of procuring a new equipment, for that new equipment also you can make this kind of assessment. What all risk areas will be there, potential risk areas that new equipment cause, and how will be for your ease again by better understanding. We have one more example that in a laboratory, if there is no stat sample so they thought that because we do not have stat sample in our laboratory, the risk will be delay in treatment of patients visiting emergency. So they had to work on that. So the statement was no stat facility in place in laboratory, and because of that, the impact was a delay in treatment. So they have enlisted the causes under the headings of protocol because there was no existing protocol of stat samples. If there were staff, they did not have sufficient knowledge. Similarly, in hospital information system, there was no system that can demarcate that there is a stat sample. They could tick in the system. There was no function of that of defining routine and stat different. Every sample was considered as same. There were a few material related things they could identify, that lack of adequate inventory in lab which could happen and unable to process the samples. They also thought of having some laboratory information system related causes like stat sample request was not visible in their laboratory information system. There was no demarcation that a stat sample is there on their computer screen. Although they had in lab some feature, but it was not clearly visible in the computer screen. They also had at some levels they thought that there would be shortage of staff, because of which the stat samples could not be processed. Maybe because of some machine breakdown or equipment breakdown, the stat samples were not processed and there was no visual identification of stat samples. So these were the things which they identified that because of this, the delay in treatment because of delayed reporting. So what laboratory has done, the failure mode is failure to identify stat sample or test from other samples. What can be the cause? Because there is no existing protocol to do that. There is no definition of stat sample, lack of knowledge in the existing protocol, no stat flash on the computer screen as we have seen, stat test request not visible through the system. Although they had a few samples, randomly people were just from their own knowledge, they were putting visual pink stickers, but it was not a protocol entry. So when they had these root cause that there was stat sample not processed in laboratory, so we can say there is no existing control measure, and because there is no existing control measure, the likelihood of detection was low. And whenever the likelihood of detection is low, we give 10 marks. Because in this case, the stat sample not visible through system, a few were putting pink sticker. So because of this pink sticker, these samples were could be identified physically. So the detection possibilities were a few samples could be detected. So that is why they have given it as 5. The occurrence, because there is no process, definitely the stat sample will be there but will not be identified. The occurrence of that delay in processing will be high. That is why they have given it number 9 and 10. The severity, because the urgent emergency patients are not given urgent care, stat care, the severity of delay will be high. That is why number 9, and RPN calculated as 810.79. Like this, it is always more than. So what corrective action has been taken? They have protocol in place now. The procedure is there. Every person is being trained. They can identify the stat samples both in HIS and LIS. New stat request they have been created that will be flashed in the computer screen as a pop-up, so that everyone, as soon as stat sample is booked, it is giving an alert to the technician in the laboratory. And there, the laboratory had created a stat request tick box in the registration window itself, where they could tick it themselves. So because of these measures, the detectability became high. So the number became 2. Occurrence, when they could detect, the occurrence came down. But if it happened, definitely the severity will remain high, but the RPN has come. Other failure mode for that, order from physician's side was not happening because there was no system. From the physician also, they could not tick it in the computer. Why? This is the rules. So existing control measure was none because physicians were not trained. That likelihood of detection was not there. And 10, 10, 8 severity, RPN 800. What they did training all the physicians how to do stat order in HIS. They had to tick. They developed a system that they have to tick it. When they were identifying it as stat, the detectability became high. They could detect it easily. But because all technicians, all the physicians were not trained and physicians were not following that rule in the system, the occurrences were still there. So the laboratory, after putting this control measure, still few instances were there they could not detect, and the occurrence was 7, severity was 8, was 2, 4. So this again has to be further. They were not accepting this because organization did not want any delay in emergency care. They further wanted some action. So this is example of further monitoring, which I have told you in presentation that we have to reassess. So I hope everything is clear to you. So stat sample not identified, no visual identification because I have told you that they were just doing randomly from their own knowledge. There was no system. Pink stickers were not available at all workstations. So now they have started using stat stickers and the detectability became high. They could detect and the number has come to 96. So like this, you can proceed further. Another example, to evaluate and treat the risk of fire in laboratory. So they wanted to assess the risk of fire in laboratory. If fire occurs in a workplace, there is a risk that people will be trapped in the fire or injured as they attempt to escape. The purpose of risk assessment is to identify where fires may start in the laboratory and anyone put at risk from fire. So they have enlisted these causes: fire alarm devices related to that, lack of devices, insufficient knowledge, non-functional devices, fire safety alarm, team, the team not trained, inadequate team, then devices, firefighting devices, lack of properly functioning devices, devices not installed at correct locations, lack of firefighting devices, lack of routine checking devices or expired cylinders. They could identify a few person.
Dr. Rinu, you are not audible. For last 2-3 minutes, you are not audible. Everything was okay, but I don't know what happened suddenly. You have muted yourself. Please unmute yourself. Dr. Rinu, please unmute yourself.
Yeah, now it is right. Okay. Thank you for letting me know, sir. So what happened is I just will go to the previous slide so that if someone had missed something. So this is in the laboratory, fire alarm devices. They want to just assess the risk of, to evaluate and treat the risk of fire in the laboratory. If fire occurs in workplace, there is a risk that people may be trapped in that. So So they have enlisted these causes. I hope this we could. So please write in the chat box. Did you listen to this fishbone chart or not? Fire related. Otherwise, I will repeat it fast. Please write in chat box. Was it clear? No, ma'am. Okay. So I'll just briefly tell. So from the starting only, I will take up this. So the third example is that risk statement is to evaluate and treat if needed the risk of fire in a laboratory. If fire occurs in a workplace, the risk that people will be trapped by fire or injured as their attempt escape. The purpose of the risk assessment is to identify where fires may start in the laboratory and anyone who may be put at risk from that fire. So they have just given these failure modes to each situation that may pose risk to fire. So under these headings, they have identified these failure modes like fire alarm, devices related, lack of existing device, insufficient knowledge, non-functional devices, fire safety team not trained, inadequate team, firefighting devices, lack of properly functioning devices, devices installed at inaccessible locations, lack of firefighting devices, lack of checking of these devices because of that expired cylinders were there. These are failure modes. Person related, lack of trained lab staff. Statutory related, maybe the NOC was not there or expired NOC, because of that checking was not there in system. And other like disaster management plan not in place, maybe infrequent mock drills were there and they could not detect the actual fire when it happens, the training was improper. So by enlisting this, they can now analyze. So what failure mode is? That no detection of fire will be there in the system. What is the root cause? Lack of existing devices, non-functional devices, or insufficient knowledge of existing devices among lab staff. Existing control measures. Now I was telling you that existing control measures in this particular example are there. I am giving you these three kind of examples that in the previous two, a few things were that there was no existing control measure and laboratory or organization is doing this analysis, risk assessment exercise. Now, in this case, most of the places, there are existing control measures in place, but still this organization is performing this risk assessment exercise. I want to emphasize on that fact that risk assessment exercise can be done in both cases, assessing where our risk control measures are there and we are just verifying whether the measures are functional or actively doing our purpose or not. And the other scenario where existing control measures are not there, it is a new service and we are proactively foresee that what can go wrong in the system so that we act. So in this case, the organization has fire alarm devices at all places. There are required number of staff. The staff is trained. The updated knowledge is there. They can handle all kind of fire. So detection is one because they can easily detect all the failure modes. When detection is there, occurrence will be less. And severity, definitely if fire occurs, the severity will always be high. So one thing I can tell that if something goes wrong, severity is always going to be high. So this number cannot be less. So multiplying all three, the RPN is calculated and you can see the RPN is less than 100. No action required because RPN is less than 100. It is okay. Now the next failure mode they have identified is fire safety team failure. Because root cause is inadequate team or lack of trained team. Maybe the number is less or the number is okay, but the training is not. So measure was taken was dedicated trained fire safety team was available in the hospital 24/7. But still, they say that likelihood, although it is better, but it is not 100%, not one. It is sometimes it may not be detected. They have given it 6 and 5. Why? The reason is that trained staff is not there and many a times the staff shortage was observed. So because of that, risk of fire could not be detected every time. Although because there were staff at some places and some staff were trained, some were not untrained, some were not trained, the occurrences were few. And as I have told you, the severity will always be less. The risk of fire is always the risky one. After that, they have calculated RPN. It comes to 162 and 135. So it means the corrective action which they have existing is not appropriate. They have to further work on this. So what corrective action they have taken? Wherever the vacancies were, they were swiftly filled, and periodic training competency assessments performed, and detective became good. Yes. Similarly, the failure mode was firefighting related to firefighting devices failure, maybe lack of devices, maybe improper functioning devices, maybe expired devices. The existing control measures that firefighting devices have been installed in the hospital, periodically tested, checking of these devices performed, and as soon as these are found expired, it was promptly replaced. Detectability was good. Occurrences was less. Severity was, if it happened, was high. Because the RPN is less, so there is no need of action. Similarly, we can go further. Statutory requirements, they were all there. Valid and receiver available, like it's good, and no action required. Disaster management plan, inadequate disaster management plan implementation, infrequent mock drills, existing control measure. Hospital has well managed plan. Compliance is checked frequently by mock drills. They can detect because the staff is there, trained staff, they can detect easily as mock drills have been protected. This is the use of mock drill, that whenever actual thing happens, we can act fast, swiftly. Likelihood was 1, occurrences was less, 4, severity was less, because they could handle it. That is why here the severity is less. RPN is 16. And I think it is quite 3 examples. You can handle everything. Now, the example which I have given you in the previous presentation in a 24/7 laboratory, this you have to work on this. In a 24/7 laboratory, IQC protocol is not there to run a quality control in the evening. Now, you have to find out the potential failure modes. In next half an hour, you have to do this. Find out the potential failure modes that can happen and what existing control measures are there. Do this RPN exercise, and one of you should present, or if you are not, you are willing to prepare some other risk activity, you want to prepare something else, prepare that, and after Dr. Neeraj's presentation, one of you will have to present, because we are doing this workshop. The purpose is that it should be interactive. Both parties should interact. Not only the trainer, the evaluation of trainer is when the participants can also promptly function. So any query you can ask there. For just quick this thing, I can show you this slide so that you can think upon the failure mode causes. Quickly go through this, or otherwise you will be biased in preparing the exercise. So I'll keep this open for 2-3 minutes. Then you have to enlist these causes, give RPN, and tell me that how will you proceed, whether I have given you effective training or Yeah, someone wants to know user error. Basically, it was a use error was actually earlier. Kya what was there? There was we used to blame a person that this person has used it or this person has done it wrong. So it was called as user error. So now this culture has changed to use error, that the errors which are happening in the system is not because of the user. We have to follow a non-blaming culture wherein if the errors are happening, it is just happening because the process needs to be corrected. There is some fault in the process, or there is some fault in the equipment, or there is some fault in the facility.
Now, thing is, we are discussing for last 2 hours how we can eliminate or how we can reduce the possibility of some unexpected happening in our laboratory. If we want to carry out some activity in such a manner, everybody is following the same guidelines, so it is better you write somewhere. What is document? Any meaningful information on any suitable medium is called document. And way of creating a document is documentation, whether it is soft copy or hard copy. So that means when standard is asking for a process, so you have to write somewhere. So documentation is required. For documentation for every step, for process every step, some procedure or further details are required. So that also you have to write somewhere. And you are doing root cause analysis, you are taking action, you are writing that action somewhere, and you are monitoring your action for its effectiveness. That also you are writing, either soft copy or hard copy. So that means documentation is required as per the standard. So there is no question कि document is required or not, documentation is required. As I said, you have to develop process, you have to procedure, you have to develop procedure, you have to maintain certain records. And otherwise also, at some places, standard says you specify qualification of the lab director, you specify calibration requirement of this particular section of different equipments. So you are specifying, so you're writing somewhere. And when you are noting down somewhere, the responsibilities of lab director shall be documented, delegation and duty shall be documented, so you're writing somewhere. And standard is asking you to develop program for preventive maintenance, program for attending CMEs, etc., program for internal audit, so that also you're writing somewhere. So that means documentation is required as per standard. And for each and every activity to carry out in an effective manner, whether it is pre-analytical or we call this as pre-examination, examination and post-examination, documentation is required, process, and then I said different type of documents. So this also I have explained to you, and then I was saying whether it is pre-examination or it is examination or it is pre-exam post-examination, you need a procedure at each step. So that means you're writing somewhere, you're identifying risk, as Dr. Rinu also discussed. So you have to develop a process, risk management plan, risk analysis, risk evaluation, risk control, risk management review, risk monitoring. We will not go in the detail again. What I want to emphasize upon is documentation is required. When you are developing a process, write down the sequence of activity and for each step, further detailing. What all you will check. It may vary slightly from laboratory to laboratory. If suppose laboratory doesn't have any collection center, then their situation different. But if suppose laboratory they are receiving samples through courier, through bike or different transportation system, their people are collecting, they have to develop process for all these things also. If suppose somebody is providing facility for home collection, how the samples are reaching, if they are of the suitable quality to perform a particular test. So that way it vary from laboratory to laboratory. We have to identify risk and we have to develop process to mitigate that risk. For risk identification, as we discussed, what are the areas we have to look for in specimen collection? If suppose you are collecting only in your laboratory sample collection area, that situation different. If you have different collection centers, you are receiving through courier also, so you have to take care of all these things. Sample transportation should be proper, lab environmental condition, reagent quality, equipments, staff competency, release of report. For that, what you are doing, for risk, you are not required to do anything extra, anything separate. You have to develop good procedures for all the activities which you are performing in your laboratory. If suppose you are addressing the requirement of 7.2, what you are doing? You are addressing the requirement of risk identification. If you are addressing the requirement 7.2, that is pre-examination. Lab environment, that is 6.3. Transportation, that is 7.2.5. Reagents, that is 6.6. And you are also evaluating vendors who are providing you these reagents, 6.8. QC is 7.3. Equipment is 6.4. Staff competency is 6.2. Release of results 7.4.1. So this shall be integrated in your implementation of 15189. So no separate documentation is required for this risk, but when a assessor is asking you, you should be in a position to explain to the assessor how you are addressing this risk. We have incorporated all the requirements in the different clauses. We are checking everything properly so that chances of errors are minimized. And for this risk control, whenever you are identifying something, you are delegating responsibility to a particular person, you develop a process flow, how you will take care of that hazard analysis. If suppose uh, this would have not been taken properly, what would have been the consequences of this risk? And because otherwise hazard would have happened, then risk assessment report. So you are then, if you are analyzing in this manner only, then you are able to score this. See all these things you're taking care in different clauses. These may be your quality indicators, or you are keeping the record separately. Wherever you are identifying something, you are keeping a record under that clause, and you can make one document for your use. In this, you are addressing where you have identified some non-conformance, and then where you have identified some non-conformance and what is the action taken by you. So for this, what you are doing, you are identifying a non-conformance and then you are checking the severity of that, whatever you have identified, what is the probability of its occurrence, and then you are calculating hazard score. Severity multiplied by probability, and then you can categorize this hazard score and what is the action taken by the laboratory for a particular situation, who has done this, and you are monitoring for your action for its effectiveness and who has verified that. And Dr. Renu has asked you to develop something at your level. When you will develop, definitely your understanding will improve, right? So in this, no separate, not much separate documentation is required. What is required? Only a process and further detailing of each step of that process and record. Now we will discuss certain situations. Dr. Renu has discussed situations with you. Now we will discuss certain more situations. When you are identifying some situation which is not acceptable, now I will give you another school of thought. If you can perform this scoring, it is very good. Severity into probability and you are calculating hazard score. But in note 2 of clause 8.5.2 in the ISO 15189, the standard is saying you follow 22367. Reshare करो. क्योंकि जहां से फाइल खोला था ना वही देखना था. ठीक है. No particular method of scoring is mandatory. Standard is saying you develop your system. You can take the guidance from this 22367. CLSI documents are also available. EP18, EP means evaluation protocol, EP18 and EP23. There is one document 35001. You will find articles in various journals also on the risk management. Now suppose you are observing floor is wet or slippery. It is a risk to patient or visitors. What may happen? Someone may fall, some may get injured. Now for this, you can either perform that scoring or some laboratory is saying, we will put the signage. We have identified this. What we will do? We will put the signage where the area is wet for the restriction of movement. Even this is also okay. This is also acceptable. Or some leg of the chair is broken. Somebody may fall. You are saying we will replace that. It's also okay. Important thing is you should be able to identify the risk. You have to see your activities very carefully so that you are identifying the risk. Suppose you are transporting sample with the ice pack. Now in Delhi, temperature is almost touching 45 and you have to transport sample and it is taking almost 1 hour. Then that particular ice pack may not be sufficient. It is not just we are transporting with ice pack. Whether that is effective or not, that also you have to see. So you have to be very careful when you are carrying out your laboratory activity, wrong test entry. You may have to collect the sample again, delay in starting patient treatment. You are saying the front office staff to reconfirm test detail with the patient before taking printout or booking slip. Because if suppose you are missing some tests, 5 tests are written and you have missed a particular test, rest of the tests were in the EDTA tube and this test is in the plain tube, then you cannot perform with that EDTA sample. So you have to collect the sample again. Or there is some issue related to washroom, then it may spread infection. So this has to be watched very carefully. You have some system of regular cleaning of the washroom whenever a patient is using. After that, the system of cleaning the washroom, use of expired disposable consumables, chemicals. It may spread infection. So check expiry status of items before use. So this way you are reducing this possibility. Even if you are not carrying out scoring, it is okay. If you are able to carry out scoring, because what is the intention? This standard need to be applied in all laboratories all across the globe. Small laboratory, large laboratory, everywhere. It is very difficult to teach all these things. Right now, there is system of checking in place, but there is no system of proper teaching or learning because it is not mandatory in the PG curriculum of people working in the laboratory, of people working in the postgraduate students in the laboratory medicine and postgraduate students in the clinical side. Samples not transported in time. It may lead to delayed reporting or maybe incorrect result. So you have to see samples are transported within defined time period. If suppose there is some urgent request, that is transported within reasonable time frame. Stock management is not proper. You now HBS AG kit is finished and now you are ordering for the kit. What will happen? Delay in reporting or some collection material is not there, delay in sampling. So you have to define minimum stock level based on your workload, based on your system of procuring that supply. If lighting is not proper at workplace, bad lighting condition, it may result in erroneous result, some accident also. So you have to see lighting is proper. Loose wire, bad earthing, infection during handling of patient. What is the reason of this? After collecting sample, needle stick injury to the recipient, needle stick injury to person working in the laboratory. So like that, you have to be very careful. You're using appropriate personal protective equipment. Your staff is vaccinated. If there is some happening, you're taking appropriate action on that. A machine is used by unauthorized users. Person may not be trained to use that machine. Erratic functioning. So you have to define who are allowed to use that machine for a particular period. This is the requirement of the standard. As per your clause 6.4.4. proper calibration of the equipment. If we are checking all these things, we are discussing this with you so that you start thinking about this. You will think many more other things also. Ki how we can take care of all these things so that we are reducing the possibility of erroneous result from our laboratory. You are checking now calibration properly. Every month you are saying in the first week we will check what all equipments need calibration in this month, and you are getting those calibrated. So you are developing a procedure. The chances of errors are reduced. Or maintenance schedule not followed properly. It also may result in. So you are developing a format maintenance schedule which you are following, and somebody who is carrying out the activity, that person is signing, and some supervisor, some senior person is verifying that. With that, chances of errors are reduced. Expired results or consumables, this may result in wrong reporting. Another thing is, at any given point of time you will have three type of reagents. One you have received in the supply, but you have not tested yet. Another type you have received in your lab, you have tested and rejected. Third, you have tested and you have accepted for patient testing. The reagents which you have accepted for patient testing shall be kept separate from the reagents which either you have not tested or you have not accepted. Then chances of wrong results, chances of using that reagent is minimized, and chances of errors are minimized. Whenever there is new lot of reagent, you are checking that reagent. With that, chances of errors are reduced. So all these things are related to different clauses of the standard. So I am again emphasizing on the same point. If somebody is asking you, because this is an important thing to understand, if a assessor is asking you how you are addressing risk management in your lab, if we have developed our procedures very carefully. We have trained our people to follow those procedures. We are maintaining various records. Time to time, we are evaluating various activities through evaluation of a particular area or through internal audit. And our all staff are trained. So that way, we are reducing the possibility of some unacceptable happening. QC material. There was one thing, failure mode effect analysis. What do you mean by mode? Mode means different ways a failure may occur, different ways of failure in some activity. Like QC result is not within acceptable limits. It may be because of expired QC material. It may be because of inappropriate reconstitution of the QC material. It may be because of improper storage of the QC material. Maybe because of some problem in the machine. Either the probe is slightly blocked, they are accepting less volume, or maybe some problem in the calibration, maybe some problem in the leakage of the tube. Anything may result in unacceptable QC result. So these are the different modes. QC may fail. So you have to do the root cause analysis and you have to find out what is the reason. Same thing may happen with your requests. You have to be very careful. Loose wiring, bad earthing, it may result in electrical accidents. So you have to be very careful in your laboratory. When you are handling patient or samples, hand hygiene is very important before touching patient, after touching patient. Results not authenticated by pathologists before issue of final test report. What you need to check, you have to check your results with IQC data. You have to check your results with clinical details. You have to do clinical correlation. You have to check your results with the previous results. That is your delta check. With that, chances of errors are minimized. Use your software, hardware carefully. Proper maintenance is required. People should be trained to use that. Suppose, as I explained to you, I was showing one case to you. A report of Madhu Kavra is handed over to Madhu Quatra. It may result in wrong treatment. This should be taken very carefully, should be checked. You're handing over report only to correct person. You are retaining sample. What is the purpose of retaining sample? If suppose some addition test is required or you want to confirm some test, so you have to store in such a manner they shall remain suitable for the addition test to be performed. Problem is, I would discuss certain situations with you. This is not the end. I can tell you 100 more situations of similar type. And if I ask you, you can also write 50, 60 more such situations. Our concern is not to only identifying these situations, how we can reduce their possibilities. And how we can reduce, when we will discuss this again and again. We will talk about these things again and again. Many of you are pathologists, many of you are microbiologists, many of you are from the biochemistry department, biochemists, some technical staff. You are attending so many conferences, workshops of your immunohistochemistry, of your molecular, of your genetics, of your immunology, in biochemistry and advanced testing to develop better understanding, to enhance your knowledge. Same thing is required in this also. You read ISO 15189 again and again. You read this 22367. You read this EP18, EP23. Now there is a standard for hospitals also. Many of you are working in the hospital. You read what is written in ISO 707101. This is released in 2023 only. You read MBBS standard, some other books on developing quality in the hospital setup. So that way you will develop more understanding and definitely it will help you in providing better care to your patients. What we need for this, we need more participation in the conferences and workshops related to this quality. And in your laboratory activity, develop process. If you're able to explain something with a process, you must have seen during your MBBS days also, during your MD days also, if you are explaining, if you are able to explain something with a flow chart, the teacher also think, yes, they have good understanding. The chances of getting more marks are more in that situation. Write down procedure so that everyone is following, chances of errors are reduced. Develop format. Format means how a record shall be captured. What all information need to be captured in that format. With that, there will be uniformity. So as I said, this format you are keeping, this performa you are preparing for individual risk identified, right? And this quality is a journey. It has no destination. And never think it is burden on you. Many of you are working in the accredited lab. Many of you have started work related to accreditation, and many of you must be planning to start this after some time. Or even if you are not planning for accreditation, start following this 15189 in your laboratory. So the quality of your laboratory will improve. You will feel more happy. When you are learning so much about immunohistochemistry, cytogenetics, other molecular aspect,